We are live now.
Okay. Good evening, all pure urology viewers. Today we are having an interesting topic, how I perform HoLEP. So it's a different topic. It will be an unedited video. So we can discuss with our eminent speaker, Dr. M. Lakshmi Ramesh sir. And we can ask questions also. It's a totally unedited video of HoLEP. And in this video, he will explain how it's HoLEP step by step. So first I will introduce Dr. M. Lakshmi Ramesh sir. He is a consultant urologist at Himabati Multispeciality Hospital, Nellore, and he has 15 years of experience in management of general and advanced urological conditions. He completed his MBBS from SB Medical College, Tirupati, and he completed MS General Surgery from SB Medical College, Tirupati, then MCH Urology from Osmania Medical College, Hyderabad. Then he also worked as consultant urologist in Arvind Kidney Center and Medicover Hospitals, Hyderabad. He now works as an associate professor urology at Narayana Medical College, Nellore, and he is actively involved in postgraduate teaching, academic activities, workshops, and conferences. His areas of expertise include endourology, uro-oncology, reconstructive urology, and renal transplantation. Now it's over to you, Lakshmi Ramesh sir. Please share your slide, and we'll listen from him.
Yeah. Sir, am I audible, sir?
Yes, sir. Yes, sir. You are audible.
Yeah. So today I want to discuss about how I perform HoLEP, sir. Sir, there are things that there are general things are there where discussion regarding the position of the patient, discussion regarding the instruments, discussion regarding the mission which we use during HoLEP. Like that, I don't want to go in depth about them, sir. I want to touch the topics where I had difficulty while performing HoLEP. Although I performed, say, around 100 to 120 HoLEPs, still I feel that I am, for every case, it is looking like a new case for me. So that's why I choose this topic so that, sir, all comments and what are all this, any modifications which I can use in future, you please let me share, sir, so that I will modify my procedure of doing, and I will refine my technique so that it will helpful for me also, sir. So
Okay, sir.
coming to disclosure, sir, there is no financial conflicts of interest. I am not for the laser. I am not against any laser company. But I will tell you the actual things that were happened while I am performing HoLEP with my laser machine, sir. Sir, this is academic presentation intended for pure academic purposes only. Coming to a small introduction about the evolution of BPH surgery, it ranges from open surgery to robotics, and the ideal surgery should be size independent, durable, safe, and reproducible. And HoLEP has all the above advantages which I mentioned. And we already know this advantage of HoLEP. I don't want to go in depth. It's anatomical enucleation. It is called endoscopic open prostatectomy by some authors, and it ensures complete adenoma removal. It has minimal bleeding, and it is size independent procedure where surgeon is happy that the patient has low transfusion rate, and it can be used in anticoagulated patients, and short catheterization, short hospital stay, and durable long-term outcomes and lower retreatment rates. So if you see, coming to the relevant surgical anatomy, we know this bladder, prostatic urethra, membranous urethra, and bulbar urethra. What I want to show you is this part, sir. This part. This is the sphincter. So during dissection, during performing HoLEP, we will see. I will show you this part, sir. This part, and this anteriorly. This is nothing but external urethral sphincter, sir, and it's the most challenging part. I will tell you during the procedure. And it is anteriorly, it is stronger, and near 6 o'clock, it is weaker, it is sparse in nature. So it is a straighter sphincter, sir.
Okay.
Coming to other important slide, you can see where the damaging can occur during HoLEP, sir. It is between 11 o'clock to 1 o'clock, and near apex, thin posterolateral fibers are there. There also, there are chances you may damage the sphincter fibers, and you may lose this apical plane. you may lost this apical plane. I will tell you what are all the mechanisms where the sphincter injury can occur during HoLEP, sir. So with this, we will go to video, sir.
Okay, sir.
Sir. I hope you are seeing this video.
No, sir. It's not visible.
Sir,
The
now
previous slide is seen, sir. Video
uh,
is not seen, sir. It's not
video,
playing.
it's playing only, sir. It is playing on my screen.
No, sir. Can have you optimized, sir? It.
I will see, sir. Okay. Sir, I am not able to share the screen, sir.
Can you? Is the video in the PPT, sir? PPT or it is different?
Sir, no, sir. It is same only. Sir, now, sir.
No, sir.
Sir, now, sir.
Now you have started sharing, sir. Yes, sir. Yes, sir. Now it's
Yes. Is it visible, sir, now?
yes, sir. Yes, sir.
Yeah, fine. So, sir, coming to basics of the procedure, sir. Before going to do any procedure, I usually habit of doing cystoscopy before going dilatation, before going to dilate urethra. And this is the cystoscopy picture. And it is around 125 cc prostate.
Sir,
Are
how
you
do
able?
you dilate, sir? One question, sir. Do you
Yeah, fine.
routinely dilate all urethra or?
No, no, sir, no, sir. I will use this metal dilators, and if the metal dilator permits me to go inside the bladder, I will dilate the complete, including posterior prostatic urethra. If not, I will dilate only anterior part of the urethra, and I will insert the instrument, and I will carry out the procedure, sir.
Up to what size you will dilate, sir?
Sir, 28, sir, only 28.
We regularly use Otis urethrotomy, sir, for the up to
Yeah,
30.
yeah, yeah. We are in the habit of doing this metal dilatation from postgraduate days. And one of our my professors, sir, Dr. Pandurangar sir, used to use artificial urethra. Either of you, we can do it, sir. Provided that you should not injure urethra, that's sir.
Yes, sir.
Sir, sir. Sir, are you able to see now, sir?
Yes, sir. Yes, sir. It's seen.
Yeah, yeah, fine, fine. Okay. So after confirming the size, sir, this is you can see the SPC which was done before the procedure, sir.
Yes, sir.
Okay. Mm. So only left ureteric orifice is visible in this case, sir. Right ureteric orifice is not visible. I tried
Yes,
to
sir.
see the right ureteric orifice also during cystoscopy.
Okay.
But because of this intravesical medial, you are able to appreciate that intravesical medial lobe, where it
Yes,
was
sir.
not allowing me to see the right ureteric orifice in this case, sir.
Big prostate.
Yeah, big prostate, sir. Big prostate. So SPC was done previously in this case, sir. So for the glands where the SPC was done, the amount of bleeding is less during procedure, and also this infection is also less post-operatively, sir. Why I don't know. I did for all larger glands more than 100 grams or 90 grams. I did. I started using SPC prior to the procedure, and I noticed this, sir. The amount of bleeding during procedure became less, and this post-operatively the recovery is smooth, and the infection rates, post-operative infection rates are also decreased, sir.
Sir, why bleeding will be less after SPC? Reason?
Sir, no, I don't know, sir. I don't know correctly the reason, but for larger glands, I noticed this, sir. Probably the amount of irritation that is caused by urethral catheter, maybe I thought it may be less as compared to this one, sir, where the SPC was done. And the second thing is the infection, sir. Infection is definitely a factor where it causes bleeding during procedure, and infection is less in patients where SPC was done prior to procedure as compared to peritoneal catheter, sir. What I noticed, sir. Whether it is true, I
Okay,
don't
sir.
know. I gone through the literature, but I didn't find any points regarding this SPC prior to HoLEP, sir.
Okay,
The
sir.
second thing is, this about the landmark, sir. Landmark Veru. So firstly, what I want to tell you is the Veru is not landmark in during HoLEP procedures. So you will go somewhat 1 to 2 centimeter distal to HoLEP in this laser procedures, unlike that of TURP, where conventional teaching says the TURP during TURP Veru is the landmark, and you should not go beyond distal Veru. So in order to avoid injury like that, but it's not in this case. In HoLEP, what the Veru is not the landmark. What I used to do is during initial part of my days of HoLEP, I used to mark the point of Veru anteriorly, corresponding point anteriorly, where I noticed that I am crossing Veru at the end of the procedure for larger prostates. Say for 50 to 60 grams prostate, this Veru and this anteriorly where I made a point. They are exactly my dissection point is lying on that point only anteriorly. Whereas in for larger glands, I am coming 1 to 2 centimeters distal to Veru during this procedure, sir. You will notice this after the procedure, sir. So the first
Okay.
foremost point is start in the paracollicular region. Why the paracollicular region? So paracollicular region, the capsule is thick, number one. Number two is the attachment of gland to the capsule is, it has got thinner attachment. You can see the, as soon as I lace the no, see, beautifully the gland is lifting off the capsule. Sir, I am using the energy for this procedure for, so we have cut two separate pedals for cutting and coagulation. For cutting, I used to use 2 joule power, 20 hertz frequency. For coagulation, long pulse, 1.5 to 1.8 joule with 20 hertz frequency. So these are the settings which I use during HoLEP. Although it is a 100-watt mission, you can use only just 40 to 50 watt, maximum 50 watt. You can use with 40 watt, you can do HoLEP of size around 120 to 150 grams prostates also. I will show you, sir. This is a case of 125 grams prostate. You can see this prostate is peeling beautifully off the capsule. I told you that the attachment is thin as compared to just in front of the collicular region, where the attachment is somewhat thicker, sir. So first you start in the paracollicular region. So start from paracollicular region. So where to end? So you are seeing vertical white fibers. So this vertical white fibers, you can boldly, you can cut with laser. You can cut with laser. And you will appreciate the line of, my line of attack. See, you can see the prostate gland is peeling clearly off the capsule with low energy, sir. Sir, do you understand? Hello?
Yes, sir. It's lifting automatically.
Yes, it is lifting automatically. The first point. The second point is, it is a gland is vascular, sir. Gland is vascular. So don't concentrate the vessels that were coming from the adenoma side. So don't concentrate the vessels that were coming from adenoma side. Automatically, you more concentrate on the capsule, so that as soon as you lift the gland of the capsule, the amount of bleeding will reduce, and the bleeders will also settle. You can see nicely how the capsule
Yes,
is
sir.
peeling off the capsule, sir.
Yes, sir. Nicely.
There are things, there are instances that will happen where you may enter into the capsule forcefully to coagulate the pelogens. So there is no wrong in it. There is nothing wrong in it, sir. So majority of the beginners or majority of the young surgeons do posterior separation easily. They will get difficulty mainly as we go towards apex. You can see I didn't do any early apical ridge in this case.
Yes, sir.
Yes, sir? Sir,
Yes,
right.
sir.
Sir. Do you have any doubt, sir? Do you have any doubt?
No, sir. No, it's
Yeah,
nicely
fine.
depicted.
Sir.
Plain is
Yes, sir.
seen, capsule is seen.
Yes, sir.
We can
Yes, sir.
distinguish between the gland and the capsule.
Sir, majority of the surgeons think that I am lifting using this mechanical. See, it is partly
There is
mechanical
no
and
force,
partly
sir.
energy. Yes, sir.
You are quite
Partly
away from
energy.
the plane.
Yes, sir. Yes, sir. So it is partly
Sir, one
mechanical and
question,
part.
sir.
Yeah, please tell me.
Yes, sir. One question. 2 joule, 20 hertz. That means 40 watt you are using.
Yes, sir. 40 watt.
At which laser this machine visits, sir?
Sir, can I disclose? I don't know whether I can disclose the name of the
Now
laser.
you can disclose, sir, for
Yes, sir.
others
It
to
is a
know.
luminous, sir. Luminous 100 watt laser.
Okay, sir. Okay, sir.
So as soon as you come towards the apex, I told you that the capsule is thin near the apical region posterolaterally.
Sure.
So just
Sure.
keep your scope near the apex. So just to rotate the scope, just to rotate the scope. See how it is going. See how it is going.
Yes, sir. Yes.
Irrespective of the size of the gland, irrespective of whether whether the gland is firm or like anything, this gland will be easily lifted off the capsule near the apical region posterolaterally.
You mean to say 6 and 9 o'clock, sir?
It is 5 and 7 o'clock, sir. It is not
5 or
6 o'clock.
6.
Near 6 o'clock position, this supracollicular tissue especially is attached firmly to the prostatic adenoma, where if you lift early, no, there are chances that you may undermine you may undermine the prostate, sir, during the procedure.
Okay, sir.
Yes, you can see this. These fibers, sir. These fibers belongs to capsule.
Yeah, yes, sir.
Yes, sir. So as you go towards this apex, what I suggest you is to use minimal energy. Long pulse width, I told you, no, vessel energy of about this one
40 watt. 2
1.8
joule.
with, yes,
Yes,
sir,
sir.
2 joule with 20 hertz frequency.
Yes, sir.
See, I am coagulating this, sir, and lift the adenoma of the capsule as much as possible, as much as possible. So because it has got some vision hindrance, I am trying to coagulate the bleeder from adenoma, sir.
Yes, sir.
I am not doing anything. Just I am applying energy. Although the vision is hazy, don't be anxious. It will settle as soon as you lift the gland of the capsule. I told you that there are some vessels where they penetrate the capsule and come out through the capsule and supplying adenoma, in which case it may be necessary for you to enter the capsule to stop the bleeder. It's a vascular prostate, sir. It is a vascular prostate. Nothing to worry. The bleeder will stop. So I used to do thulium also, sir. Thulium also. The main
Yeah.
difference which I noticed between the thulium and HoLEP is you if you apply some amount of energy at one point during the thulium procedure, so it will create charring. Unlike HoLEP, where if you
Yes, sir.
want to
More
if
charring is there.
yes, sir, if you want to use thulium like HoLEP, just use sweeping movements, sir. Fast sweeping movements, unlike that of HoLEP. See, I am using sweeping movements to lift the gland of the capsule. In case of thulium, you use at a little bit faster rate. to in order to avoid charring. So this I am doing the left part of adenoma. So lift the gland as much as possible before going to right side.
Sir.
Now I came to left side, sir. Sir, right side
Sir.
of the patient.
Right
As
side of
soon as,
patient.
yes, sir. As soon as you go in correct plane, the gland will feel like anything.
Yes, sir.
You can appreciate this.
Yes, sir. Yes.
And don't stop. You keep on coagulating. It will just this instrument and this energy which we are using take you to into the correct plane till 11 o'clock position.
So every time your fiber will be at 6 o'clock position.
Yes, sir. Yes, sir. Yes, sir. Now I will change, sir. See, this point I want to tell you, sir. So now I want to go in the groove between the left lobe and the capsule. So in order to do that, I will release some mucosa. Now, I will release some mucosa and intentionally I will coagulate some part of gland also. So that I want to take entry in the groove between the gland and the capsule. Now I gave it to the correct plane.
Correct.
See, now I am lifting the gland. Hope it is clear, sir.
Yes, sir. Yes, sir.
Yeah. I showed you the diagram, sir. I showed you the one diagram of sphincter. I will show you that diagram again. And don't panic. You are not going crossing the sphincter, and you are going to follow the gland configuration only with this technique. Yes, now you can see. Now you can see the margin of the sphincter fibers. So margin of the sphincter. I am just releasing the mucosa and the gland from the sphincter fibers.
Yes, sir.
Now I am going to 1 o'clock position, sir.
Yes, sir.
So even if you enter into the gland, you enter the gland so that ultimately you can readjust. That is the main advantage with this laser. So you can readjust and you can start it again.
Yes, sir.
See, I came to 12 o'clock position now. 12 o'clock position and I am freeing the fibers. Sir, in the middle of the fossa, what I want to tell you is in 12 o'clock position, the capsule is very much thin. And you can perforate the capsule either during laparoscopic simple prostatectomy or during HoLEP, where you can get fluid extravasation. Patient may ultimately land into suprapubic fullness and discomfort like that. So during release of apex, you please keep your instrument on the lobe which you dissected. So that it will make the fibers tight and you can easily separate the apical fibers.
Sir, what you told, sir? Sorry, pardon, sir.
Sir, you after separating to some extent, you please keep the instrument on the lobe
Okay.
which you separated. So that
That means above the lobe.
above the lobe. So that
Just press
the
it down.
fiber, yes, sir, press it
Press it
down.
down and clear the.
Exactly, sir. Exactly. So that your these fibers, no, what you are seeing, they will appear
Yes,
as a
sir.
vertical, say, vertical rope-like things. So that
Yes, sir. Yes.
you can cut it easily and you can have control in the anteriorly with no problem. So again, I came back to lower part near 5 o'clock position, and I am dissecting the gland of the capsule. See now, see. I am not doing anything.
Yes, sir.
Just you stick on to the basics. See, you can separate easily. You can separate easily. You can go till 12 o'clock position also. See. Because I detached already the apical fibers near the see apex from the sphincter. I am going boldly that I got confidence that I am not going to injure this sphincter.
Yes, sir.
I think I am clear, sir.
Yes, sir. Yes.
Yes, sir. One important point is you can see this vertical blood vessels, sir. They perforate the capsule and they supply the adenoma. So this is one. This one also one identification point where it says that
In the
you
perfect
are on the
place.
capsule.
Yeah.
Yes, sir. So with no hesitation, turn your instrument boldly, so that you will be on the plane and you are dissecting correctly the adenoma of the capsule. I will tell you the disadvantage also with this technique, sir.
Yes, sir.
Follow the plane, sir. That's all. That's all. You'll go to the bladder neck easily. So this gland is firm, sir. It is not allowing me to go to my line of attack. That is the reason why during dissection you may encounter that I am entering this prostate adenoma deliberately, but it is not so, sir. This instrument is not allowing me to go into the line of attack. Now I
Yes,
am
sir. Yes.
now I am completely concentrating on the left lobe. I am separating left lobe of the capsule. See how the dissection is going on. So as soon as I reach large blood vessels, I came to know that I am going to reach bladder neck. No, I am starting to the left side. See, are you able to appreciate this horseshoe shaped one, sir? Sphincter? Hello? Hello? Hello, sir?
Hello, sir. చెప్పండి సార్.
Ah,
హలో సార్. హాయ్ సార్.
are you able to appreciate that one, sir? The
Yes,
sphincteric
sir. Yes, sir.
portion. Yes.
This is the mid bone.
No. This is the right lobe, sir. This is right lobe.
Yes, sir. Yes.
This is the right lobe.
Nicely it is lifting, sir.
Yes, sir. Yes, sir. So regardless of the size of the gland, if you follow the capsule, no, it will lift like
Yes, sir.
anything, sir. So always attack towards the lobe, sir, towards the prostate. Instead of going to this one capsule.
Capsule.
Ah, yes, sir. So if you go in a correct place, sir, this gland will become smaller. Regardless of size, you can do magics with Hall baby. So once I noticed this large vessels, I came to know that I am reaching bladder neck. I am separating the gland from sphincter mucosa. Here you can use two options. Two options are there for releasing this one, sir. One option is you can use coagulating part where the long pulse is employed to dissect the lobe of the capsule, or you can use this one also, sir. Short pulse laser.
Yes, sir.
Now I am going to go to 12 o'clock position, right lobe, right part.
Yes, sir.
Separation is almost over, sir.
Yes.
Even I apply traction on the gland now, I am not going to injure the sphincter.
There is no mechanical pressure.
There is no mechanical pressure, sir. There is no mechanical pressure. With this technique, you won't get to mechanical pressure or anything. You can play like anything. You can play like a football in a football ground.
Yes,
Now
sir.
it
Yes.
is now it has got separated from the sphincter.
Yes, sir.
So this gland is very close to sphincter, sir. During initial part of cystoscopy, I didn't show you that this gland is very much nearer to this sphincter, sir.
Okay.
I will show you towards the end of the procedure. I will show you the clear demarcations of this one, where the sphincter is actually and where is the, this one defect. Now I am separating the 11 o'clock part, close to the bladder neck.
Yes, sir.
What you used to do, sir, this procedure, or you are going to release the apex first and proceed for a further?
Sir, I will give this apical release incision, sir, all around first.
First, okay,
Then
okay,
parafollicular.
okay,
Then unblock, sir, like you do, unblock only.
okay, nice, nice, nice. See this bleeder, sir, now. See this bleeder.
These
I will show
vessels are
you.
landmark.
Yes, vessel is a landmark for bladder neck. See the vessel. In order to coagulate the vessel, I entered the capsule and I started coagulating.
Yes, sir.
It didn't stop. It bleeded again. Say, I am reaching bladder neck, sir.
Yes, sir.
And for 120 grams prostate, it's around only 40 minutes, sir. That's all.
Super, sir.
Yes, sir. So I am separating, unlike that of other dissections, sir, I am separating bladder neck from periphery to center. I
Okay,
am
sir.
dissecting the gland of the bladder neck from periphery to center.
Okay, sir.
I will tell you the advantage also, sir, later. If you start in the 12 o'clock, 6 o'clock position, there are chances that you may leave the gland underneath the bladder neck, and there are chances that if you boldly do, no, it may go subtrigonally.
Yes, sir.
I am separating the gland from side. Have you noticed it, sir?
Yes, sir. Yes, sir.
Yeah.
Nicely it is coming.
That's all, sir. That's all. See, now I started coagulating this vessel, sir. It didn't stop actually. I
Yes.
entered the capsule, and it will create some anxiety, some little bit of anxiety element in this type of prostate, sir. There is no need for you for us to become anxious, and this laser will completely, definitely is going to stop this type of bleeders. With this, with thulium, no, you will get hemostasis, but not like this, sir. You will get some degree of if you burn a single point in thulium, no, you will get a charring like that, sir.
Yes, sir.
Mm. It started again. Bleeding started again. This time a long vessel. This type of vessels go smoothly with thulium in contrast with holmium, sir.
Yes, sir.
Mm. See, a long vessel. It stopped. For dissecting anteriorly, these sweeping movements are very much essential, sir, in order to dislodge the lobe of the capsule. So as soon as you complete this portion, you will go to the bladder neck. I will show how to identify the bladder neck.
Yes, sir.
I am dissecting the gland and I am going towards 6 o'clock position. It is full of love. See now, sir, some vertical fibers are coming. Some vertical fibers are coming near bladder neck. It indicates that we are going to enter the bladder. Hello?
Yes, sir. Yes, sir.
Sir.
Clearly seen, sir. Fibers, vertical
Yes,
fibers.
sir. Yes, sir. Yes, sir. You can enter directly into the bladder and start the dissection from bladder, or you can separate remaining attachments, you can enter into the bladder. See, the gland is peeling like anything. I am moving towards the bladder next. Just lift the gland off the capsule.
Uh, uh, we do no hand enucleation in open prostatectomy.
Yes, sir. Yes, sir.
It's perfect plane it is there.
Yes, sir. Yes, sir. And follow this plane in majority of the cases, it will take you to complete prostate. And sometimes it appears that you are leaving some part of gland where you can see after resection, no, you can do as and when required, sir.
Yes,
There's no
sir.
need for you to hurry. And after resection also you can adjust like that. See, the gland is peeled off from the capsule.
But
You join this lateral part to the anterolateral part and anterior part.
that you have to come more anterior.
Yes, sir. Yes, sir. See, thing is, the main disadvantage with this technique is, no, sir, you cannot,
Sir.
after dissecting all this part, no, easily you can do dissection. And after completing all this part, no, some part of the gland near the midline gets attachment to this one capsule near the bladder neck. It is very difficult to lift the gland, sir. It's very difficult. I will show you this in this video, that part
If the
also.
gland is heavy, especially.
Heavily, sir. Heavy, that one, and this gland is firm also. I'll show another gland where it is a soft cheesy like, and it lifted off like anything, sir.
Okay,
See,
okay, sir.
now I entered the bladder. You can
Yes, sir.
appreciate this vessel also.
Yes, sir. Yes. These bluish fibers are
Yes, sir. So instead of going from below upward, I am separating this gland of the neck, sir. See how it comes.
up to down, sir. You are doing.
Always up to down. It's best, sir.
Yes, sir.
You can avoid inadvertent capsular perforations with this technique, sir.
Yes, sir. Your SPC balloon is seen.
Yes, sir. Yes. Now I am separating the gland of the bladder neck and capsule. There is it works. This technique works better when there is intravesical medial lobe. where you have to remove the complete gland in order to ensure that smooth post-operative UFR. Separate the things, what are the fibers that will come in front of you, you separate them and you can gain the gain the access in the planes.
Yes, sir. You are putting some pressure, sir, to create the plane.
No, sir,
Just
no.
pushing the lobe.
No, sir. Just
Nothing.
I kept nothing, sir. Nothing, nothing. If you push some pressure, no, it may go. It may injure the capsule, sir. Just
Mm,
you keep
bleeding will be there.
the scope in the correct plane and you fire the laser. You can notice the small blood vessels where you can coagulate with long pulse width laser. How do you separate bladder adenoma from bladder neck, sir? Near bladder neck, how do you separate? Hello?
Yes, sir. Yes, sir.
How do you separate this adenoma near the bladder capsule, sir? Bladder neck, sir?
Bladder necks are like this only, sir.
Or
But usually
you
I
want to
will
proceed
go
from
into
6
the
o'clock
bladder from
to
11 o'clock or 1 o'clock, sir.
okay, you want to
Then
separate from
slowly.
6 o'clock to or to going from below
No, sir.
above
No,
or
sir. Above, sir. Above, sir. Above
above
is
below?
always
Yeah,
safer.
safe. Yeah,
So I
yeah.
enter in at around 1 o'clock.
Okay,
Then I enter 1 o'clock. Then I will slowly release clockwise.
okay, okay. Nice, nice.
Then opposite lobe, same.
And that's all. That's all, sir. Yes.
Once we enter the perfect capsule, we can play with the gland from any
Yes,
side.
sir. That's all. Yes, sir. Sir, do you use hypotensive anesthesia for this or
No, sir.
no? No. Okay. Okay.
Do you use, sir?
Sometimes, sir. Sometimes I ask my anesthetist to keep pressures low.
If more bleeding is there, we can ask.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Vascular glands,
For separation also, I used to
sir.
ask my anesthetist to keep pressures low so that I can do
Around
as early
what
as
you keep, sir?
possible.
Around what you keep?
100, sir. 100 systolic.
Good point. I will take care, sir. Next time I will try.
Sir, sir. Especially near the bladder neck, sir.
Yes, sir. Yes.
And while dissecting near the bladder neck, I'll also ask my anesthetist. Some
I
glands,
feel difficulty during this bladder neck, sir, for the floor.
yes, sir.
When the whole gland weight comes to the floor
Yes, sir. Yes.
and you have released all around,
Yes, sir.
and there is always risk of undermining.
Yes, sir. Yes, sir.
Then,
I got difficulty in lifting the gland off the floor, sir,
yes,
with the
sir. Yes,
scope.
sir. All the time, always you have to go inside and come from known to unknown.
Yes, sir. Yes.
From bladder neck to then distally.
Yes, sir. But unless you use this technique, no, it is not always possible to separate intravesical medium, sir.
Yes, sir. Yes, sir.
With this technique, I feel this technique is good for this intravesical medium lobe, where you can separate
Yes,
easily.
yes, sir. Nicely it is coming.
Unlike the other parts, see the degree of attachment, sir, here near the
Yes, sir.
bladder neck.
Yes.
This is also one problem where I noticed during my HoLEP, sir. This is the ureteric orifice, sir. This is the left ureteric orifice. I am separating this intravesical medial lobe from bladder neck and I am going to the opposite side. You separate as much as possible. Be careful here, bladder neck. Use long pulse width in order to avoid excess heat damage. Use laser in coagulation mode or use in cutting mode, sir, near bladder neck. Hello? Hello, sir?
Yes, sir. Yes, sir.
Use cutting mode or coagulation mode in this one, sir, in bladder neck.
Cutting only, sir.
Cutting only. Okay.
What do you use, sir?
Coagulation only, sir. Coagulation only. So that you can appreciate the right ureteric orifice also, sir.
So to avoid ureteric orifice injury,
No,
sir.
no, not ureteric orifice injury. Avoid excess heat to the bladder neck, sir.
Okay, sir.
Initially, for
Have
some
you
few
ever
cases,
noticed any bladder contracture, sir? Bladder neck contracture after HoLEP during all these procedures?
only one case, sir. Only one case, and that also it healed well with one cystoscopy.
So
Uh,
good, sir. But
uh,
actually, usually it doesn't happen compared to TURP.
yes, sir. With this
Since it's
technique,
very less.
I am happy. Yes, sir.
Yes, sir. Yes, sir.
See, now I am
But anyway, I
separating
will
very, very
try.
fast.
Good point you have told. I will try, sir.
Sir, sir.
But anyway, it is very slow when you use coagulation.
Yes, sir. Yes, sir. Yes, sir. But I prefer to use coagulation only near the bladder neck, sir.
Okay, sir.
Mm. It's almost done, sir. It's almost done. This is the part where I always have some little bit difficulty in pushing the gland into the bladder. I separate the gland from all parts and it has got only some attachment. I will show you the attachment also. This is the
Yes,
attachment.
sir.
This is the attachment, sir. Last attachment. Every
Yes,
time
sir.
I am facing difficulty in separating this attachment of the neck of the capsule.
Yes, sir.
This technique. Now I enter the bladder, sir.
Almost over.
Almost over, sir. Almost over, sir. In 5 minutes, I will start morcellation. It is over, sir.
Sir, one question audience has asked.
Sir, please
How
tell
to
me.
prevent ureteric orifice injury while dissecting intravesical
So
median lobe?
you can see, sir. You can see directly. Where I am using this coagulation mode, and I am on to the bladder neck rather than going into the bladder, sir.
Yes, sir. Yes, sir.
You can see clearly. See, if I go in a correct way, no, you are easily lifting
Yeah.
the gland off the capsule. See,
Yes, sir.
you
Yes,
can
yes, sir.
appreciate
Yes.
it.
Yeah, sir. Yes.
That's all, sir. That's all. See, I will show you the ureteric orifice. Previously, it's not visualized, no, during
Yes,
cystoscopy.
sir.
Ah. Some degree of tactile sensation you feel, sir. You feel when you are dissecting the bladder neck, where
Yeah.
if you enter the bladder, no, you won't get that feel, sir. That will differentiate you from the, whether you are in this one bladder neck or you are in the bladder.
Yes, sir.
So it has not separated now.
No, yes.
That's all. Yeah, I am using in coagulation mode, sir. I am going
Yes, sir.
close to the gland.
And we can clearly see the bladder also.
Yes, sir. Yes, sir. I will show the RFS also, sir. This is the intravesical medial lobe, sir. This is a big intravesical medial lobe. Instead of
Sir,
going
one
near the
question,
base, sir, please.
what setting do you use for coagulation? They're asking, sir.
Sir, this is the RFS. For coagulation, I use long pulse, 1.5 to 1.8 power joules with 20 hertz frequency.
Same 20 only.
20 only, sir. 20 only.
Max you are using 40 watts only.
That's all. That's all. See, there
Though
is
it
this
is
is
100-watt laser.
no, I am not using it all, sir.
So in TFL, what setting do you use, sir? TFL laser?
Sir, I don't do TFL more commonly. I did only 2 to 3 cases demo mission on demo mission. I used this IPG laser for that, and
Yes, sir.
they kept some minimum settings which I don't remember also, sir. They kept minimum
Okay,
settings
sir.
only. But I am happy with
Okay,
this
sir.
IPG laser. It has got minimum charring effects as compared to other lasers, sir. They
Yeah,
say
yeah.
that I tested only few of TFL machine, sir.
Sir, nicely it is coming,
That's
sir.
all, sir. That's all. Now the lobe is in the bladder, sir.
Yes, sir. Many people are appreciating, sir.
Oh,
Nice
thank
technique.
you. Thank you, sir. Thank you. Now you can coagulate.
Yes, sir.
This is the bladder neck region.
Yes, sir. Great, sir.
Yes, sir. And before this morcellation,
Sir.
because of the full bladder, it may appear that you are off the bleeding like that, sir. As soon as it collapses, no.
Sir.
So the bleeders will start bleeding and it create disturbed vision. So
Yes,
in
sir.
order to avoid that, it is before this morcellation, it is better to coagulate with laser. Wherever you see this reddish areas and bleeders like that. This is
Yes,
the
sir.
this is the this is the one. This is the apex. This is Veru.
Sir.
And the procedure lasted for only 40 minutes, sir.
Yes, sir. Yes, sir.
Yes, sir. Even I did a maximum of around 180 grams prostate,
Sir.
where I completed the procedure in 50 minutes, sir.
Nice, sir. Super.
Where you won't get any disturbance with this laser machine.
Sir.
We are using old Versacut machine, sir, for morcellation. See this, see the sphincter fiber, sir.
Yes, sir. Yes.
Yes, I will show you, sir. I will show you. About.
At the end, sir.
They're not at the end, sir. They see this. See this.
Yeah.
This is the sphincter fiber, sir.
Yes, sir. Yes.
Before the sphincter. See,
Yes, sir.
that's all.
Appreciated.
I entered it.
Yeah,
It is
yes.
this the reason for this presentation is this gland is very close to the sphincter, sir.
Yeah, sir. Huge glands usually project beyond the veru, sir.
Yes, sir.
They
Yes, sir.
come close to the sphincter.
You can appreciate horseshoe shape also, sir.
Yeah, yeah, sir. Yes, sir. Nicely
Yes,
it
sir.
is.
Yes, sir.
Super.
Yes, sir. And this patient had transient incontinence for say 1 to 2 weeks, and now he is happy with this flow.
Yeah, sir. Yes. Usually, almost maybe 50 to 60% will have, sir.
Yes,
But
sir.
it resolves
Yes,
in
sir.
1 week.
Yes, sir. Yes, sir. Yes, sir. But I don't find any different results with the early apical release as compared to this technique, sir. I did early
It's,
apical release as well.
sir,
But
sir.
what I had difficulty in early apical release is during the procedure. No, there is sometimes some amount of gland will be left over near the apex. That will be
Correct.
very difficult to remove after at the end of the procedure. Unlike this procedure, sir.
We'll try, sir, this one. Next, nice
Yeah,
technique.
yeah, please, sir.
But
You
from
please give me feedback
beginning,
also, sir.
yes, sir, yes.
Yeah.
From beginning only, we are using this our release incision and do it. We'll try.
Okay, okay. And what I notice is some part of gland, I don't know others' experience, sir.
Apical region, it is left, but it is not that great, sir. It is not
Yes,
that
sir.
much blocking.
Okay,
Usually,
okay.
I do cystoscopy after 1 month for all patients and follow up.
Nice, nice,
So
nice.
I check it.
Uh,
Initial days it was more, but now as
okay.
we do, I give the incision very close to the sphincter, sir.
Oh, great, great, great.
Just 2 to 3 mm away.
I had a chance of doing cystoscopy for a few patients, sir, where it revealed a very good, nice fossa. It's almost looking like another bladder.
Super, sir. Super demonstration.
Sir. And this is the morcellation, sir. Morcellation, you use Versacut, old version only, and it
Sir.
is doing a good job. So we are planning to buy a new one. Hope we'll do it so, sir. Sir, if you want to see another video, I will show you the post to TRP, post biopsy,
Sir.
if time is there. No problem.
Yes, sir. Yes, sir. Just quickly you can wind up, sir.
Quickly, I will show you.
Sir.
Okay. Can I close it, sir? No?
Yes, sir. Yes, sir.
Do you have any doubts, sir?
No, nothing, sir. So just this, what are the complications you have faced, sir, in initial phases like that? You are now pro master.
No, no, no,
So,
no, sir. Sir. Sir, generally speaking, I don't have any, till now, I don't have any complications, sir.
great, sir.
Generally speaking. But because of, sir, I am lucky that I have my seniors where they demonstrated me like anything,
Yeah.
because of which I
From
could
whom
do.
you learned, sir, this HoLEP technique?
Sir, seeing other techniques, others techniques only, sir. Don't have.
Like whom you follow?
Sir, Dr. Dheeraj is there from Vijayawada. Dr. Vamsi
Okay.
Krishna is there. They are very
Yes, sir.
good at
Yes.
doing
Yes, sir.
HoLEP
Yes,
or
sir.
Tulem laser, sir.
Yes, sir. Yes, sir.
I saw them, but I didn't have any opportunity of talking them about this technique in detail, sir, with them. In conference
One
only I made them. In
one
conferences.
question one person has
Please,
asked, sir.
please, sir,
Sorry, sir.
please. Ah.
How coagulation mode will prevent injury?
Sir, it's a long pulse, sir. This
Long
amount
pump.
of pulse delivered is less, sir, as compared to short pulse.
Okay.
Sir.
And one more question I have asked you, how to prevent ureteric orifice injury while dissecting intravesical part?
So stay
This
in the
you have
bladder neck,
mentioned.
sir. Stay in the bladder neck. Stay close to the bladder neck. And as soon as you lift the gland off the bladder neck, stay close to the gland.
Sir.
This will prevent most of the injuries, sir. Sir, this I will show it a faster mode. I got only, I am not near perfect, sir. I want to get perfection in the in HoLEP cases. And as soon as I do some nearly say uh, 500 to 600 cases, then I can say that we can do like this, sir. But now still I am in the budding stage. I cannot say that we can do like this or like this, sir. So here I am giving early apical releases. These are early apical release emissions. The reason for the me to present this case, sir, I went outside the gland multiple times. I dissected in between the gland, and again I adjusted and I went to capsule after some time. This is 94 cc prostate, sir. Sir, is it visible, sir?
Yes, sir. Visible, sir.
Yes.
I think, sir, after prostate biopsy, some kind of inflammation will be there.
Yes, sir. Yes, sir.
And
And previously TRP was done for this patient. Before TRP, they did biopsy. And they found that it is not malignant, but he is having a high PSA, sir. He is having 47 PSA. PET scans were done outside where they didn't show any signs of malignancy. Later, I had a discussion with this patient regarding this, sir, it may turn into malignant. Final biopsy may give malignancy. If you are willing only, we will proceed for a HoLEP like that. And the patient showed his willingness and he came for surgery. Outside TRP was done for 120 grams, and our MRI showed 90 grams. So he again presented with low drug symptoms and with a creatinine of 2.81.
Okay, sir.
Okay. Sir, do you have time, sir? So that I can, no
Yes,
problem,
sir.
sir.
Yes, sir.
If you have any, so if we are running short of time, we'll
No, no
conclude,
problem,
sir.
sir.
Conclude, no problem, sir.
People are asking questions, sir. One more question.
Yeah, please.
Sir, have you ever faced any problem while morcellation if SPC bulb is there?
No, sir. No, sir. One time, no, this bulb was punctured.
Ah, okay.
That only I got that one, sir. Sir, if you see this, no, the reason for the presentation, no, I am leaving some amount of supracalcular tissue, sir. One
What,
time,
sir?
no,
Some amount of
supracalcular tissue. Just above the Veru, I am leaving some
yeah.
amount of tissue, sir.
The pudding,
So
what I
it is
told.
it is the thinnest part, sir. It is the
Yeah.
thinnest part where for one case, no, it was ejaculate ducts were open, and post-operatively patient had painful ejaculation, sir. So in order to
Okay.
avoid that, no, I started leaving some amount of tissue in the supracalcular region.
Yeah. So this today's case, what I told you, sir, 130 cc also, it is
Sir,
post-roasted biopsy only.
okay,
I have
nice,
only done
nice.
biopsy 1 month back
Sir, nice.
for raised PSA,
Okay.
but a little bit difficulty was there, sir, multiple planes.
Yes, sir.
Huge
Yes, sir.
inflammation was there, sir.
That's what happened, sir. That's what happened. It's the same in this case also. But
Sir,
by God's grace, I reached this correct plane, sir, towards the end of the procedure.
yeah, you are maintaining very well, sir.
Yes, sir. I will show you the end appearance, sir.
Yes, sir.
Yes, sir. So this is as usual, sir. This is as usual. I dissected a gland of the capsule completely. This is the end point, sir. This is the end point.
Yes, sir. Nice, sir.
Sir. So thank you, sir. Can I conclude, sir? Can I conclude?
Yes, sir. Sir. Thank
Yes,
you
sir.
so much, sir. Nice presentation.
Oh, thank you,
And
sir.
all
Thank you.
the time plane was so beautiful.
Sir,
It
sir.
looked very easy.
Sir, thank you,
It
sir.
looked
Thank you.
very easy and reproducible. Everyone can do it.
Yes, sir. Thank you, sir.
So
Thank
thank
you.
you, sir. Super presentation.
Sir, thank you so much, sir.
It's like eclipse learning enucleation from Dronacharya. You have
No, sir.
watched
No, sir.
others' videos only and you have mastered it so perfectly.
No, sir. No, sir. It's all
Every time
help.
that gland is in correct plane.
Yes, sir. Yes,
It
sir.
is
Yes,
like
sir.
you made it very easy.
Sir,
Now I
sir.
think after watching this video, a lot of people can practice enucleation.
Yes, sir. Yes, sir. Yes,
So
sir.
super, sir. Super video.
Thank you
Thank you
so
so
much,
much.
sir. Thank you so much, sir.
Thank you
If
so
any
much for
comments are there,
joining.
please let me know, sir. No problem, sir.
Okay, sir. No, a lot of people have appreciated, sir.
Thank you so much,
Lot of
sir.
people,
Thank
lot of
you.
people have appreciated.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thank you so much.